Hello, and welcome to MED-EL's latest in the series of Surgery Online. My name is Kevin Vukovich. I am the Senior Product Manager for BoneBridge. Today, our focus is BoneBridge surgery, a review of unique cases. Specifically, we'll be looking at revising Sophono to BoneBridge. A few housekeeping notes before we get started. If you could please utilize the functionality within the Zoom system and name yourself, whether it's your specific name, your organization, or your country, just letting us know who all is in attendance today would be of great value. As well as to avoid any background noise, all of the participants are muted today. If you do have questions throughout the presentation or at the end, please feel free to utilize the chat functionality, type in your questions, and our moderators will assist us with getting those questions answered at the end of the presentation. Okay. And as far as a stable internet connection for anybody who has any additional programs going, you may consider closing those, minimizing, just to alleviate the bandwidth on your system. We will be utilizing some video throughout the presentation today, and that does at times cause problems for some of those that are viewing the presentation. And then finally, again, the questions and comments are welcome. Please utilize the chat feature for that. Today, I am joined by Professor Magnus Teschner from Prosper Hospital in Recklinghausen, Germany. It is my honor to welcome him to join us and share his experience in revising the Sophono implants to an active transcutaneous device with BoneBridge. With that, I do want to emphasize MED-EL's mission of overcoming hearing loss as a barrier to communication and quality of life, but doing so through intact solutions. So whether it be our cochlear implant systems, the non-surgical bone conduction solution with Adhere or the BoneBridge, this is something that we do truly focus on and as a way to innovate and make life easier and better for our recipients. For those who may not know, I'm actually a bilateral BoneBridge recipient myself. I was implanted about 6 years ago. I was actually implanted with the BCI 601, which you see here on the timeline, was first launched in 2012. The first generation audio processor was the Amade. We had the Samba and now have the Samba 2, which joined the BCI 602, which was launched in 2019. So as far as active transcutaneous bone conduction solutions, the BoneBridge truly was the world's first of those within that class of implantable devices. We also cherish the legacy that we have with all of our systems going back to 1994 in the cochlear implants, but truth with the BoneBridge system too, the compatibility of the newest processors with our legacy devices. So again, the BCI 601 is utilizing the Samba 2 audio processor. The second generation implant was created in collaboration with our surgical partners, such as Dr. Teschner, and looking at the candidates for these devices, whether it be a smaller transducer, self-drilling screws, the flexible transition, really focusing on the surgical handling, as well as the anatomical flexibility of this device to meet the unique needs specific to the anatomy, be it syndromic, previously drilled anatomies, craniofacial anomalies, whatever it might be. The BoneBridge truly does lend itself to a wide population when it comes to the candidacy. And then looking at the complication rates as well, very low complication rates through delivering not only the choice of direct drive or intact skin, but direct drive and intact skin. So the sound quality of what a direct drive implant can do, but reducing and or eliminating those complications that were inherent in some of these legacy devices due to penetration of the skin with an abutment or the pressure-based systems, these passive, similar to the Sophono system. So looking at hearing outcomes, the aesthetics of a low-profile device, and then just honestly, the wearing time, the recipient comfort, alleviating or reducing that pressure that was required from some of these legacy devices that was detrimental or frustrating to patients with regard to their overall wearing times and comfort with these devices. So, looking at that flexibility of the device, the BoneBridge, be it the BCI 601 or BCI 602, the surgeons have the ability to bend that transition up to 90 degrees in either direction in the horizontal plane or 30 degrees in the lateral plane. So thinking about that is, the vertical plane. So thinking about that as far as, again, the unique anatomy from a previously drilled mastoid, such as my own, these revisions where perhaps the surgical area has been compromised, these are things that do truly provide benefit to the surgeons in the OR. And then finally, wrapping it up by looking at the reliability, we do have this long-term data for the 601, over 11 years worth of cumulative survival rate data, and looking at nearly 98% in that 11-year history, with including accidents and impact. In the 4 years, over 4 years worth of data now for the BCI 602, and coming in at over 99.5%. Again, including accidents and impact. So with that, I get ready to hand this over to Professor Teschner to share his experience in revising these legacy devices, the Sophono, which was a pressure-based passive transcutaneous system. So with that, thank you, and I will pass it on to Professor Teschner.
Hello, everybody. Nice to meet you all. And best regards from Recklinghausen in Germany. I'm happy to be with you. First, I would like to introduce myself a little bit. I'm, after 19 years working at Hanover Medical School, now the head of the Department of Otolaryngology, Head and Neck Surgery in Recklinghausen, and head of the implant program here in Recklinghausen. We implant hearing devices and we be there for our patients. And we have in Recklinghausen a long history of ear surgery. And this is our nice hospital in a very cozy surrounding, and I feel comfortable, and my whole team feels good, and my whole team is there for your problems of the especially of hearing and of the ear. And if you need an implant, you can always come to us. So we have a certification for implantation. It's called CIVE in Germany, certification of the implant program. And we are here in Germany in the western part, more or less in the middle of Europe. So we are there for everybody. And the directions to Recklinghausen, of course, today everybody should go by train, and we have a train so that everybody can come with a high-speed ICE train. But who wants to come by car, of course, we have two highways in direct neighborhoods. So you all should be able to visit us with your issues and questions for hearing devices. The Prosper Hospital in Recklinghausen has a long history of reconstruction of the external ear of the pinna, especially in patients with dysplasia of the pinna and atresia of the external auditory canal. And I would like to thank very much Ralf Siegert and his team, who did this fantastic surgery within the last 20 years. And so we had a lot of patients with these surgery, and also with the Sophono implantations. And it was the Sophono implant was performed in so many patients here, because in that former years this was state of the art here in Recklinghausen. And but now we know, since I took over the hospital 2 years ago, we know that Sophono was a good implant, but there are better implants for the patients, and the implants that provide better hearing. So that was the goal we want to focus. And we have here a CT scan of a patient with a dysplasia of the external auditory canal on the left side, and we don't see any external auditory canal, and the pinna is also this with a huge dysplasia. So there's no external auditory canal, and you see cochlea pretty nice without any malformation. So the hearing in that patients should be fine in case of the inner ear function, the bone conduction, but these patients always have an airborne gap. So after reconstruction of the pinna, the external auditory canal is mostly not being reconstructed because the reconstruction of the external auditory canal did not lead to good audiological results. That means the airborne gap was still there after surgery. So that was the device of Medtronic, the Sophono Alpha, that was used in many patients. It's a transcutaneous device with the magnet, and the skin is intact, and they have the device with the magnet fixed on the skin, and it's connected to the alpha magnet under the skin. So we have this transcutaneous device. It is active device. So you see here one of these alpha magnets with a 50-cent coin in comparison. That means we have 2 magnets implanted under the skin and fixed with 5 screws. And these patients have now often problems. And you see here a CT scan of a bilateral Sophono, more or less a bilateral alpha magnet. And you can see here the very good the magnet and the screws in the bone. And here in a different slice, the magnet, and this is the way that the implant of the Medtronic company worked with the outer part and the magnet, the alpha magnet under the skin. In that former years, it was okay for the patients, but as I said, now we have better options to treat the patients. This device was MRI conditional, so you could do some MRI scans with that. It needed not much surgical steps, and it was not so heavy implant that lead to problems. But the Sophono had a lot of problems, or have a lot of problems, because first of all, the Sophono and the alpha magnet is out of service. And that's a big problem for patients who have issues with that device. And moreover, this device has a transmission of vibration and not a transmission of the signal for vibration. As we know, the BONEBRIDGE has signal for the implant, and the vibration comes from the implant under the skin. And the Sophono did did work in the other way. The vibration was transmitted to the magnet, and then the bone did vibrate. So, I mean, we all know this is the better way. It should be is the vibration of the implant, and the bone bridge has a good vibration. So bone bridge is, for that reason, the better implant. Also, the comfort for the patients was not good. I see many patients who says, okay, I don't like the magnet, and I don't like the device, and it's very uncomfortable. And as well, we often see a weak gain in these patients, especially at 3 or 4 kilohertz. And they are not satisfied with the implant. However, we have to say that it was a transcutaneous device, and the skin was intact, and it was not a percutaneous device like maybe the Baha screw. So if the patients want a new implant, they also say, I want to implant with an intact skin. So we have to choose a transcutaneous device, and the bone bridge is a very good implant for that issue. So many patients and many problems with the Sophono device. Here we have a pure tone audiometry of a patient with a external auditory canal atresia. And we see the combined hearing loss on the left side. This is a typical audiometry audiogram of these patients, and you see bone conduction threshold in at 500 hertz at about 15 decibel and up to 40 dB at 4 kilohertz, and a complete airborne gap. And when you measure the Sophono, we always see a weak gain at 3 or 4 kilohertz, as I mentioned. And here is a typical audiogram. This is a free field Sophono on the left side, and the right side was masked by headphones. And you see here the gain is about 40, 50 decibels. So the threshold is 40, 50 decibels. So that's not a good solution for the patients. And the Sophono has not that power we need for these patients. And you see also, if you measure these in a free field in the speech audiogram, you see also speech discrimination at about 40% here at 65 decibels. So that the patients, I understand that the patients are not satisfied with these devices. This is patient 2 who had a little bit better speech discrimination at about 55% at 65 decibels. Also masking the left side via headphones. And this patient had a good bone conduction. So the best condition for the bone bridge. And also you see here the free field Sophono on the right side, also masking the left side via headphones. And the threshold is between 40 and 60 decibel. And that's not enough for patients with that inner ear threshold, so with that bone conduction threshold. So we need for these patients better solutions. We need for these patients better implants than the Sophono. Here we see the audiogram on of patients with a Sophono on the right side. We have here the bone conduction on the right side. It is pretty nice bone conduction, and we see also here on the right side the free field Sophono on the right side. And it's also the same a weak gain at 3, 4, 5 kilohertz, and we see also the threshold at about 40, 50, up to 60 decibels, and that's not the best option 2024. So we need to do something. And we did so far in many patients. So we explanted the alpha magnet. This is what it looks like. So we have here the reconstructed pinna on the left side, and we open the skin behind the ear, and we expose the alpha magnet, and you see the implant is in the very bony implant. So it's a little bit bone over the screws, a little bit bone over the edges, a little bit bone over the middle part of the alpha magnet. So we expose the whole alpha magnet, and we expose the whole screws, and sometimes we can use our screwdriver to remove the screws, and then the implant gets out very easily. But sometimes the screwdriver doesn't work, so we have to go another way. So we need go for drilling out the screws, and this is a little bit traumatic in some patients, but not in all patients. So in that way, or in that way, we are able to remove the magnet and prepare everything for the implantation of the bone bridge. What we do is after explantation of the Sophono, we do an MRI scan, because you never know if since implantation something happened with the brain, something happened with the inner ear, inner auditory canal. So if there's acoustic neuroma or whatever, and we all know with the alpha magnet we have issues to see. We have issues with good results of the MRI scan. So we remove the magnet on one day, and the next day we do an MRI scan, and the day after we implant the bone bridge. Sometimes we have issues like very deep screws. You see here the screw of the Sophono, of the alpha magnet, going deeper than the bone. And you can think about what happens if it goes deeper than the bone. And we remove the alpha magnet, and we found an CSF leakage in that screw. So we fixed the problem. We fixed it and put in some Tarosil. So no CSF leakage resulted after fixation of that problem. But you have to be aware of these issues in all devices with screws. So please do an CT scan before removal, that you are prepared for every issue for that. And after removal, please do an MRI scan, that you see every structure, everything, every problems that can appear within the years in the brain or in the inner auditory canal. So that's why we do it, and I think we have a good procedure with that. And after removal, of course, we go for bone bridge. And this is what the bone bridge is. You all know the bone bridge. It's for patients with conductive hearing loss and patients with single side deafness as a cross device. And that's the function of the bone bridge is is clear for everybody, I guess. So the technical data of the bone bridge in the dimensions here for drilling, and the indication for the bone bridge goes up for the inner ear threshold of up to 45-50 decibel bone conduction threshold for bone bridge, and any air conduction threshold is acceptable in addition to that. So we have a wide range of indications and wide range of implantation, because the patients who got the Sophono and or have problems with the dysplasia of the external auditory canal and the pinna are almost young. So this is a congenital problem, and the patients are 2, 3, 4, 5, 6, 7, 8 years after, up to 50, 60, 70 years. And we can implant, and we do implant the bone bridge also in children 5 years up. So we have a wide range for patients with that indication. And I have a small video of the bone bridge implantation. You see, it's drilled. I drilled the hole in the skin, and now I have self-cutting screws, and it's very easily to use a screwdriver to fix the implant. Now it's fixed. Now we have a second screw. Tight, not too tight, and that's it. So that was the bone bridge implant. Just drilling bed and fix the screws, and that's it. So everybody can do that, and the patients have a very good device for their hearing problem. So we have a control cone bone conduction after bilateral bone bridge implantation. This was the patients of atresia of the external auditory canal. So the masking was at 80 dB. And you see a very good bone conduction after the surgery, a very symmetric bone conduction. That means this device is safe for the inner ear. In terms of this procedure is safe for the inner ear. You can do it with no risk for the inner ear. And we have here the bone bridge measurement bilateral without noise on the right side and on the left side. And you see here very good results. These are the first results of a patient with a bilateral bone bridge. And you see at once this is much more better than the results of the Sophono, and the patients are much more satisfied than the Sophono. We have speech discrimination with this Sophono, with the bone bridge without noise in a free field at 65% on the right side, and here 65% on the left side in the first fitting. That means this patient has very good results as well, and he is still in training and still in optimizing. So these are not the final results. We expect speech discrimination at about 80, 85, up to 90%. This speech discrimination at 65 decibel. So in my opinion, this is the best aided situation and the best situation for the patient as at all. Also with noise, if we have do measurements with noise, we have good results here. BONEBRIDGE bilateral with noise. We have 65 at 65 decibel. We have here 45% speech discrimination. So good results as well. Again, this is not the final measurement. This patient is still in measurement and in the fitting procedure. So we expect here also in noise much more better results than that. So we have here in Recklinghausen implanted the Sophono alpha magnets 102. We had about surgeries of the pinner and with dysplasia of the pinner at about 300, and so 102 did get a Sophono alpha magnet, and we expect explantation of the alpha magnet and implantation of the bone bridge in about 80% of that. So we, since I took over here 2 years ago, we started right now to explant the alpha magnets and implant the bone bridges, and these are the first results of our program, of our changing program, if you to say in that way. And we expect within the next years many patients to change these devices. So again, we are happy here in the Prosper Hospital, my whole team, and Dr. Pivko, my audiologist, and I are very happy to welcome you here in the Prosper Hospital in Recklinghausen. And let me just conclude or close with some German words. That means hearing, hören, and aufhören means stop, please stop. But I would say auf Wiederhören, that means see you later, but hear you later. And within just an invitation for our third Recklinghausen ear surgery course with many surgeons here in-house and great faculty. I would say auf Wiedersehen. Thank you very much. And if you have any questions, please let me know. I will be happy to answer you any questions you have. Thank you.
Thank you very much, Professor Teschner. And again, for those who do have questions, please utilize the chat feature, type in your questions, and we will get those shared with Professor Teschner for your answers. One question that did come in earlier, do you typically do these revisions from Sophono to BoneBridge or any of the other legacy to bone conduction devices to BoneBridge? Do you do those as a single procedure, or do you stage this procedure, perhaps do the explantation, wait for the site to heal, and then implant BoneBridge at some time in the future?
Yeah, we do a stage procedure because we have to explant it on one day, and we have the MRI issue. So you can say it's one in-house procedure, but it's staged surgery. So maybe Thursday we explant it, the Sophono, and Wednesday we do the MRI scan, and directly on Thursday we implant the bone bridge. This has the advantage that patients comes to the hospital just one time, and we have a chance to do the implantation in the same procedure. We have an MRI scan, and we don't have so much issues with scar tissue. So if you do this stage procedure, explant it, and wait, you will have a lot of scar tissue and maybe infection. We didn't see in this 3-day procedure no infection at all, though it's a safe, and that won't be a problem.
Perfect. Thank you for sharing that. And then any other tips or tricks, things that you've encountered in perhaps removing the device that you want to share with others as far as words of wisdom for things to be on the lookout for when removing a Sophono?
Yeah, also if you remove the Sophono and the screwdriver doesn't work, so don't hesitate, don't panic. You just use your drill and drill it out. So if you have no problem, you can drill it, and you don't have to a cutting drill. You don't use a cutting drill. Use a diamond drill, and then the dewar won't be a problem at all. Please be aware uh, where and please have in mind where you want to put the bone bridge in later. So if you drill like this, then you don't have bone for the bone bridge. So you have to think about, okay, this is the place the bone bridge comes in, and then be careful with that place, and then you can work around. That won't be an issue. That's
Perfect. Thank you. Thank you. And then as far as just the anecdotal feedback from these patients who've been revised from Sophono to BoneBridge, you shared the audiologic data, but what are they reporting as far as just their overall satisfaction, quality of life? I'm assuming it's longer wearing times because they no longer have the pressure to transmit the signal through the skin. But I'm just curious if you have any observations you made from just comments that the patients have made to you.
they are not satisfied. The Sophono patients are not satisfied at all. First of all, about the hearing results, they don't say, I don't hear anything. So, and they have something, they have pain. And when I tell them, okay, there are better options, they want to have the better option. And just don't, please let me get rid of the metal in the brain. I want a active implant. The skin has to be intact, and I want to have a transcutaneous device, and not just a magnet in there. I want to have an implant that works. That's good. It has 10, 15 years history, and it is established on the market, and not the Sophono. It's out of service. So they want to have a good implant, and then I say, okay, we can remove the alpha magnet, and then we implant the bone bridge. We can do that.
And they tend to be genuinely happy then after surgery and activation. Perfect.
Yeah, they're I see in the all the patients in the follow-up, and they're happy. Yeah. Good. It was a good. Thank you so much that you recommended this device, and thank you so much for helping me. And they are happy. So
Wonderful.
Then I'm happy as well.
Happy surgeon, happy patient.
Yeah, that's it.
Yeah. And then another question that's come in while we've been chatting, the minimum age that you there in Recklinghausen in your program, is there a minimum age which you would consider for BoneBridge, or do you use the approved guideline of 5 years and above? What tends to be the practice in your program there?
So in Hanover, we implanted 5 years up, and that's what I do in Recklinghausen as well, 5 years up.
Okay.
So
Perfect.
why not implanting children 5 years up? So they have to hear as well. So and they could have to they deserve a good device as well. So and then I implant them, and they are happy as well. So no issues. Sometimes the parents are a little bit, oh, does he really need an implant, and why, and why? And then I explain, okay, this is a good device. Hearing is better. He needs the hearing for education, and he has to hear in the school, has to hear in the university, has to be in a traffic. Where does the car come from? Right, left, front, back. So hearing is so important, and this is what I explain the patients and also the parents, and then the parents say, okay, you're right, and let's implant, and then we do it.
Thank you. Yes, definitely for the speech and language development, socialization, just comfort in the classroom, and all of those definitely valuable aspects for the children and acclimating and thriving in the educational environment.
Yeah.
I also noticed you have a bilateral recipient that you
Yeah.
showed
Yeah.
there. Just your general thought with regard to bilateral implantation for bone conduction. Is that tend to be a standard of care? Do you see the bone conduction field growing into more of a bilateral implantation mindset?
So God gave us 2 ears.
Yeah.
That's it.
Yep.
So despite to the reimbursement issues in the countries different, but 2 ears
Yep.
bilateral. Why not? That's all to say.
I couldn't agree more myself, but I'm a bilateral recipient. But I know even from when I was fit with my first hearing aid in the 80s, one ear was enough, and then it wasn't. And then with cochlear implants, it was the same. One ear was enough, and now we
Yeah.
moved on to this
Yeah.
bilateral. And I think
Yeah.
we've come full circle when we're having the same conversation with bone conduction. But I think we're getting to the same place where we've been with cochlear implants and hearing aids is bilateral is a standard of care in the places that will allow for it where reimbursement's there. So,
but we have concerning the bone bridge, we have to be faster than in the cochlear implant. It took so many years for accepting bilateral implantation, and we have in the accepting bone bridge implantation, we have to be faster.
but I think now that we've cleared the pandemic and the subjects are able to come back in for more testing and data collection, I think we're going to see the wealth of information grow as more and more institutions such as your own do studies and provide that data to support the arguments for the bilateral implantation.
Yeah.
So
we
perfect.
do it bilateral here in Recklinghausen, and you are invited to come to us, and we can do that.
Well, thank you. I'm out of ears myself, but I'm sure there
Yeah.
may be somebody else in the audience who might be a candidate.
Yeah.
Well, it looks like we've answered all of the questions that were in the queue. With that, I will start to wrap things up. Give one last chance for any questions to be typed in or added to the chat feature. It looks like it's quiet. So with that, thank you very much, Professor Teschner. I do greatly appreciate your time. Thank you for our attendees for joining us. I will promote both the surgical video library from MED-EL as well as the professional blog for surgical topics. QR codes there on your screen for both of those and accessing them. Please visit, check them out. There are some great topics there, some of which tie into our discussion today. So thank you very much. And then stay tuned for the announcement for the next date and time for the upcoming surgery online. That should be coming into your email or announced through LinkedIn and other social media platforms in the not too distant future. Thank you very much. Have a wonderful day and appreciate your time.
Thank you very much. It was a great pleasure to be with you. Thank you so much.
Thank you.